Good morning. I'd like to thank SAGES for the opportunity to be here today and for the moderators. I'm Tom Robertson. I'm a fellow at Carolinas Medical Center. Okay, so I have no disclosures. The senior author's disclosures are listed. So postoperative pain management in bariatric surgery patients is a challenge. One of those challenges is because opioids have long been a foundation for post-op pain, and we all know that they're associated with multiple side effects, sedation, respiratory depression, and those are particularly important in our patient population in bariatrics because of the high prevalence of obstructive sleep apnea and the increased risk of opioid-induced respiratory depression. So we feel that multimodal anesthesia is very important. So as far as TAP blocks, they've been shown to decrease rescue opioid use following bariatric procedures, laparoscopic chole, and cesarean section. And in particular, in ultrasound-guided TAP blocks, they've reduced total morphine use immediately in the recovery room and 24 hours post-op. And in regards to the way our TAP blocks were performed, we utilized liposomal bupivicaine, and we feel that because of its multivesicular delivery system, it allows for the continuous release of the local anesthetic, and it's up to 72 hours. So the objectives of our study were to compare the effectiveness of a liposomal bupivicaine TAP block and rescue opioids to opioid-only PCA. Our primary outcome was total morphine equivalents received, and our secondary outcomes were lengths of stay and postoperative pain scores. So this was an IRB-approved, retrospective, single-surgeon study of 440 laparoscopic gastric bypasses and sleeve gastrectomies. The groups were the TAP block group, where they received a preoperative ultrasound-guided TAP block, and postoperative rescue narcotics as needed, and the PCA group, which had opioid only in a PCA form. Both groups received 24 hours of IV Tylenol, and on post-op day 1, the groups are transitioned to PO Lortab. So we calculated from our retrospective review the total morphine equivalents that were received for their entire admission, and these were converted to standard IV morphine, and that's how we compared it. Lengths of stay were calculated from day of surgery to time of discharge, and then pain scores were collected. The TAP block was performed in the preoperative area under ultrasound guidance by anesthesia. The mixture of the local anesthetic was 20 milliliters liposomal bupivicaine, 20 milliliters of 0.5% bupivicaine, and 40 milliliters of saline. Total volume of 80 for 40 milliliters on each side. And this is injected into the plane between the internal oblique and the transversus abdominis. On the left is an ultrasound picture from a couple weeks ago from our anesthesia team. And on the left side, the pre-injection, you can see the layers of the external oblique, internal oblique, and transversus. And on the right, the post-injection, you can see the bubble there of the local anesthetic in between the internal oblique and transversus abdominis. And the drawing on the right is just a further picture to show the transducer where their needle would be placed, and then the yellow bubble there is the local anesthetic. So as far as our results, showing this graph, on the left side is IV morphine equivalents. The left bar graphs are the bypass group, the right is sleeve. The white bars are PCA group, and the right is the TAP block. And there was significant decreased opioid use in both groups. 62% less opioids in the bypass TAP group and almost 60% in the sleeve group. Now, as far as our secondary outcomes for lengths of stay, the bypass group had one less a day for their length of stay, and the sleeve group had almost a day, and these were both statistically significant as well. For the pain scores, what was surprising based on how there was decreased opioids received by the TAP groups, the pain scores did not change. In fact, the tap block bypass group actually had statistically significant increased pain scores at times 0 and 12, the graphs A and B. But graph C, at 24 hours, the pain scores were unchanged across all groups. In our analysis, what was interesting in this graph shows, although nothing was significant, is that on the right side, the tap block groups for bypass and sleeve, they had a much higher percentage of unreported pain scores at all time points compared to the PCA group. And that's just part of there's multiple potential reasons, but due to the retrospective nature, it would be difficult to really ascertain why that is. So in conclusion, there was significant decrease in total morphine equivalents in the tap block patients compared to PCA in both laparoscopic gastric bypass and sleeve gastrectomy. There was a statistically significant reduction in length of stay for patients that received a tap block. The pain scores were not decreased postoperatively. And because of the retrospective nature and that being one of the limitations, a study with a strict adherence to pain score collection is recommended. Thank you.